Today, we're specifically going to be doing a little bit on head and neck grossing, some of the more common specimens, and we're going to, if we have time, touch on gross photography. But before we do any of that, I kind of wanted to give you just sort of an overview of my perspectives on gross pathology. And so you may have heard everybody's kind of soapbox, right, about grossing, but you really are the kind of caretakers, right, of that tissue in the gross room. You're the first to see it. It is the primary source, right? It is the disease. And so everything that you do starting with the gross specimen results in a cascade of events, right? That results in a diagnosis. And so please, always treat, these are your patients, right? These are the closest you will get to physically putting your hands on a patient in many cases. And so treat it with respect, but I'm sure you all know that, but I always want to emphasize it. And so sometimes, if mistakes are made, right, they cannot always be undone, right? We can't just, we can't always go back and recreate things after they've been cut up. So do not ever be afraid to ask questions, ask for help. You are basically expected, to sort of know nothing as you start, and we will teach you. But in order to be able to teach you, we have to know what you know and know what you don't know, and there's no shame in asking. For pathology, I don't know. I take pride in our specialty because without us, not a lot of treatments will happen, diagnoses won't happen, right? And so who have I already sort of promoted to about my Plato's cave allegory? Have I said this to any of you all yet? So one of the first sort of experiences that I came across in UChicago as an undergraduate student is the cave allegory, and it really struck me. And so in this allegory, there are these people at the bottom of the cave, and they're kind of looking at the wall, and there are these people behind them that are casting shadows from the light that's being sort of in the sort of hole of the cave. But they don't know. They can't look back. They can't get up. They're just staring at these shadows. And for their entire life, that's truth, right? Truth are these shadows. But at some point, maybe they break free, they turn around, they walk up outside the cave, and they realize oh, these were just shadows cast by something. And the reality is out there in the world with the real sunlight instead of the, firelight. And so beyond, who knows, right? One could ask, well, who knows if these people, even at the top of the cave, if that's reality? Maybe there's some third dimension beyond that, right? However, based on what we know of our current world and state, I sort of like to think about, maybe radiologists or others who look at the shadows on the wall, right, as the ones being in the cave. And we are the ones that have come and seen the light, right? So we actually get to deal with the primary source, the tissue. We are the gold standard, not really, but you know what I mean? We try our best to be. And so I really take pride in this. And I think that, this is how I kind of view us in the context of the medical specialties. Okay. So questions. Great. So I like to sort of prepare ourselves for sort of what we like to think about before we even touch a case, right? So conceptually, we want to know why was this procedure or surgery performed? Does the patient have some kind of prior pathologic diagnosis that can help guide our evaluation of the specimen? If they do have a prior pathology, what was the anatomic site? Is it the same or different? Did they receive any treatment prior to this procedure? Are we expecting to see residual lesion or not? And what will the clinical team want to know? This is kind of higher level, right? This is once you get on service and you start understanding those clinical questions, you can prepare the specimen based on what you think the clinicians are going to want to know. I'm sure Corey and the gross room staff is teaching you about technically what you need to know before you open the bucket, right? Is the correct labeling there, the patient's name, the specimen site, the type of tissue, the laterality, the type of procedure, right? All of this you're going to go through in training, but just remember that we have to ask ourselves if everything is done correctly in the electronic database. Before you cut the specimen, right, we want to ask ourselves, is it a cancer case or a possible cancer case or a benign case? This may dictate your approach to inking, to sectioning, to sampling, whether it needs ink at all, how much of it needs to be sampled. What is the site and the anatomic orientation? Often, as you know, there are sutures from the surgeon, and as you already have found out, sometimes those sutures are wrong, right? Because sometimes they hand it off the field, they give it to the med student, to the junior resident, and the resident's like, oh, I think that's this hole, right? And they put a suture there. Some of these surgeons suture it themselves, as I'll show you later in this talk. Whenever possible, We prefer to maintain anatomic orientation based on those anatomic designations rather than clock face orientation, which I'll talk about later. But sometimes there's one suture and it may say this suture is superior. Well, I don't want you going and saying, oh, I'm going to designate the suture at 12 o'clock as opposed to superior, because that removes information, right? You are now taking an anatomic orientation and you're giving it a clock face number, which means nothing. So if possible, preserve that anatomic orientation. Again, we'll talk about that later. If you don't understand the anatomic orientation, talk about it with someone. For tumor cases, of course, we want to think about margins. How are we going to take those margins? Are they en face or are they perpendicular? Who of the first years can tell me what the difference between an en face and a perpendicular margin is?
Would be more or less parallel to the margin that's created perpendicular, so essentially the tumor and then the surgical margin.
Yeah, exactly. So when you take an en face margin, you're taking that entire face of margin, putting it down in the cassette, and so that entire tissue, right, is margin. Whereas perpendicular, it's usually, as you said, right, perpendicularly oriented to ink, and you can see the tumor as it approaches that margin. So only the ink is the true margin. Okay, cool. And mostly, you want to sort of pre-plan how you are going to serially section the tissue, because this is going to then help you dictate in which manner or orientation that you ink it. So all of these questions come to pass when we are triaging specimens. When you're grossing, right, you want to think about important tumor cutoffs, for example, for staging. Overall size cutoffs change depending on the organ or the tumor that you're dealing with. So go pull the CAP or the AJCC protocols. How deep is the invasion? What is the extent of invasion or involvement of other anatomic subsites or structures? What is the distance to those margins or structures? And then what will your sections look like, right? So again, we're kind of getting more and more advanced as we go down the page. At some point, you're going to think to yourself, oh, I want to see this in relationship to that on the slide, and so I want my section to be like this, right? So you have to do this kind of three-dimensional to two-dimensional back to three-dimensional translation every time you gross a specimen, because when you see it in 3D, the person who sees it grossly may or may not be the person who sees it on sign out, right? And so, but that person on sign out needs to be able to go back and understand how that three-dimensional thing was created. So, this back and forth between 3D and 2D, I think, is very important, but very challenging for a lot of people because it's not a way we're normally used to thinking. But practice, practice, practice. And then need for ancillary studies. So we always want to ask ourselves, is there some fluid, right, that we will be putting this tissue in that will retrospectively be harmful to our future needs, right? And so our standard fixative is formalin, right? And so one, is there anything that needs to be done fresh before I throw it in formalin? And a lot of this is either the tissue bank stuff that is done by the PAs, right? So they take that fresh for tumor banking for investigators. Especially when you go to heme service, they do karyotyping and cytogenetics and cell, right, basic cell culture on fresh. That comes to play with heme path. Not so much fresh that we need in surg path. Sometimes we like to take specimens for electron microscopy, in which case the fixative is glutaraldehyde. Sometimes we need immunofluorescence, in which case the fixative is this special Michel Verzus fixative. Mostly the clinical teams already kind of have this and they can already put the tissue in it, but just so you're aware, if you see these names, right, what's going on. Some tumors like neuroblastomas, et cetera, might require snap freezing for various studies. And then lastly, what is very, very common, right, on everything is molecular testing in next generation sequencing or FISH. Formalin fixed paraffin embedded tissue is perfectly fine for this. Fresh smears off of the specimen or in cytopathology are fine for this. But any hard tissues or bony tissues require special decalcification for molecular testing. Have you guys talked about this yet at all?
We've seen the two different areas.
All right. And what are the two different types of decalcification solutions that we have? And HCl and EDTA, okay? And so HCl is the harsh acid. It will destroy nucleic acids. You cannot do NGS on it. EDTA is a gentle chelating agent. It's totally fine. It just takes a lot longer. So my word of thumb for decal is decalcification always happens after fixation. No exceptions, right? You still need to fix the tissue before you decal it. So don't ever throw something fresh straight into decal. You'll ruin it. Any tissue or tumor that requires decalcification, think about, are there any soft bits, right, that you can submit undecalcified? Because if so, great, then you don't even have to deal with EDTA. So submit as much as you can of soft tumor undecalcified. If you cannot do that, definitely select some for EDTA and then maybe some for HCl. Except in a large specimen, right? The exception is if this is a small core biopsy or something where tissue is sparse, then we will just do the entire thing in EDTA because we don't have a lot of tissue left. Mostly the PAs gross those core biopsies and they deal with it, but there may be times where it's relevant to you. Always feel free to ask questions before decalcification in case you're not sure where to put things. That's kind of my general overview. Questions? Okay, we'll move into the head and neck. And so the head and neck is very anatomically small and complicated, and there are a lot of subsites and a lot of different types of tissues, which for me, why it's very interesting. And so we have the squamous mucosas, right, that line the oral cavity, the pharynx, the larynx. We have the nose and paranasal sinuses, which of course are lined by more respiratory type mucosa. We have the major and minor salivary glands. We have other glands, i.e. thyroid and parathyroid. So lots of diversity of anatomy. Don't forget, we also have skin of the head. We also have bone, maxilla and mandible and calvarium, right? We have eye, we have ear. Of course, the only thing we in head and neck path don't touch is brain, right? That's neuropath, but everything else we touch. So it can be very challenging and very diverse. And so I would like to kind of focus on two of the most frequent growth specimens that you'll see for head and neck, which are thyroid and mucosal or skin ellipses, which are kind of conceptually similar. If you ever get a more complicated head and neck specimen, larynx, pharynx, maxilla, mandible, whatever, always come talk to us about it. We are more than happy to look at it with you. So let's start with thyroid because it's my favorite organ and it is probably one of the ones that you will gross very frequently. We see over 300 thyroidectomies a year here, which means greater than 1-ish per workday. I know it can be 0 some days and 5 on other days, right? We want to think about orientation, inking, sectioning, and sort of correlate between the findings on ultrasound, the findings on FNA, and then the findings on gross in order to come to a final histologic diagnosis. Where applicable, I've linked the gross website page on the bottom. I know you all know where that website is, but just in case. So we have to ask ourselves, why is this gland on my table? Is it for medical disease that's sort of refractory to medical therapy like Graves' or Hashimoto's? Usually this gets a total thyroidectomy because the entire gland is involved by whatever this medical disease is. There may be benign nodules that are causing symptoms, right? They're totally fine, but they're compressing the person's neck organs and they require some kind of resection for treatment of those symptoms. Then you actually have neoplasms or nodules that may be either questionable, benign or malignant, not certain on FNA, and they require a definitive diagnosis, so those get diagnostic lobectomies. And then you have tumors that are overtly diagnosed as carcinoma on biopsy, and those just require treatment. Sometimes it may be a lobectomy if the cancer is small and restricted. Sometimes it's a total thyroidectomy if the patient is going to need additional radioactive iodine therapy, etc. So any of these reasons you may see thyroid. Sounds like you've already seen these in the gross room, but you remember that the anterior surface is sort of convex. It sits right underneath the longitudinally oriented strap muscles of the neck. The posterior surface is generally sort of concave and rough, right, because it sits right on the trachea. In this case, you have a pretty nice little isthmus right in the center, a beautiful butterfly lobe. We've now started inking our posterior surfaces red to know which is the side that is in contact with the trachea. And our anterior then can just be our 3 colors. So right is blue, isthmus is orange, and left is black. So when you serially section it, you'll know anterior, posterior because of color, and then red, and you'll know laterality because of sort of blue versus black. Traditionally, you'll see this also in places like prostate. Why is left conventionally inked black? This is just sort of my guesstimate. It's kind of like, why is superior inked blue and inferior inked green? I believe that's on lumpectomies, right? Because it's like sky is blue, grass is green. Well, left is sinister, right? Left is bad. So left is always black, right is always blue. If you have a trouble remembering it, this is how I remember it. Okay. So types of specimens we might get for thyroid include a lobectomy or a hemithyroidectomy, meaning either a lobe without the isthmus or a lobe with the isthmus. And usually this is stated on the requisition, so I usually kind of go with whatever the surgeon says, or if you see the isthmus, fine. We only ink the cut parenchymal isthmic margin. In this case, orange. We don't bleed that ink onto the peripheral isthmus because there's a difference in the margin, right, between the isthmus, which is in contact with the rest of the lobe, and the periphery, which is in contact with the soft tissues of the neck of the patient, right? So that's why for these particular specimens, we sort of try to restrict that orange ink to the cut isthmic margin because it's means a different thing than the peripheral margin. And notice I'm not saying capsule, right? Because the thyroid doesn't actually have a capsule. This is just the peripheral kind of soft tissue plane. For total thyroidectomies, you may encounter ones that have a nice wide isthmus, like we just saw, or a very narrow isthmus. If you're having trouble finding the isthmus, fine, don't worry about the orange. You don't have, or you can just put like a little stripe down the middle. It doesn't matter. There's anatomic variations. It's fine. Okay. And sectioning, generally a lobe is very easy, just top to bottom, perpendicular. You'll get your isthmic margins, right, in these cross sections. And then for your totals, depending on how wide your isthmus is, you can choose to sort of amputate the isthmus differentially and cut it sagittally as opposed to the lobes, which we normally do transversely. But thankfully there's not, too much variability in approaching these. With the exception of this, so you may have read about this modified transverse vertical method of sectioning in the Gross manual. And you'll notice that the only difference, between this and this is that at some point, some of these internal sections are going to get also perpendicularly sectioned because there may be a large dominant nodule that is called like follicular neoplasm or not a cancer case, right? This is a case where we are trying to determine if it's cancer. And in order to determine if it's cancer, we need to see if there's capsular invasion. And the best way to do that is not by looking at the capsule like this, right? By looking at the capsule perpendicularly. And so we need the capsule of the nodule, right? Not the capsule of the gland, because there is no capsule of the gland. So we then want to section the tips of the nodule and the tips of the nodule perpendicularly. That's all that means. If you are uncertain whether to use this technique, just call me and ask me. This is one of our former residents who did this technique on a lobe. You can see the superior section with the suture up here. There's nothing happening throughout these slices until they get to here. And then this slice had the tip of the nodule. So then this slice, they perpendicularly sectioned the tip of the nodule. They went transversely, and then they perpendicularly sectioned the inferior tip of the nodule, again, in that appropriate manner, okay? When we are looking at thyroid specimens, I always want to know what the FNA diagnosis was. That may help your grossing, right? So FNA diagnoses fall into the Bethesda categories. You'll certainly learn more about this on Cytopath, but essentially overtly benign, fine, that's usually correct, benign. Suspicious for malignancy or malignant is usually overtly malignant, that being usually papillary or medullary, or sometimes higher grade like anaplastic carcinomas. But something like a follicular carcinoma diagnosis cannot be made on FNA because it's not a cytologic diagnosis, it's an architectural diagnosis. You need capsular or vascular invasion. So these are the kind of ones that often get this indeterminate category, meaning the nuclei are atypical but not overtly PTC, so I can't call it, but I'm worried. Or the architecture is really cellular and I can't call it follicular because I don't have the capsule, but I'm worried about it, right? So it's these that sometimes get our reflexed to molecular testing, and it's these that we kind of want to be making sure that we sample appropriately for final pathologic diagnosis. So what do some of these categories look like on gross exam? So carcinoma tends to be very pale compared to background normal thyroid, whether it be sort of white or tan or even sometimes maybe yellowish if there's necrosis, sometimes hemorrhagic. You'll notice that some carcinomas have a very fuzzy, right, infiltrative border. These tend to be things like papillary carcinoma, really fuzzy, right? This one in the middle has a very clean border, but it has satellite nodules, right? It has a little nub in here, a nub in here, a bigger nub in here. When you see these satellite toses, that's also indicative of malignant of carcinoma. And some have more of these kind of cerebriform, almost like lobulated borders. Some of these are medullary and some of these are papillary. And some of these might even be like a follicular carcinoma, but you can't necessarily know that based on the look, but you know that it's certainly abnormal compared to background thyroid, right? So it's those kind of things that we're looking for. In something like this that's relatively well circumscribed, we want to see if there are any areas maybe like here where the capsule or the periphery kind of blurs, right? Those are the areas where invasion might be identified. Benign has a wide variety of appearances. Benign nodules can often look very shiny and gelatinous, right? Because they're full of lots of colloid. They can even sometimes look hemorrhagic or even necrotic or infarcted because of FNA that sometimes causes it to infarct. This on the bottom right has no nodule, but the thyroid is sort of diffusely enlarged and kind of beefy, right? So this is more of a Graves' disease type of picture. Sometimes benign adenomas can actually have a little capsule, right? And so it's these cases where you'd want to think about submitting some extra sections of this periphery to see if there really is a true capsule there. In the grossing manual, I basically tell you, don't ever entirely submit a large capsule, like 5, 6 centimeters, because that's gonna be like 20, 30, 40 blocks, unless you talk with me first. Submit some up front and we can always go back. There are a few scenarios in which you can submit the entire specimen, and I'll go through those in a second, but it's okay to sort of start with a few and then we can always go back for more. This is also a common appearance of benign thyroid nodules, very multinodular, very shiny, right, and glistening and gelatinous. This is follicular nodular disease. These are all benign colloid-rich nodules. So how much to submit? Weight, so all endocrine organs, as you know, should be weighed. For lobectomies or hemithyroidectomies, about 10 grams, or totals like 20. You can just submit the entire thing sequentially from superior to inferior, because by that point, once you've excluded like a couple normal or whatever, you're basically left with nothing in the bucket. So it's fine, just submit it all. You can put one, or if they're small, 2 slices in a cassette, fine. For things like medical disease or multiple benign nodules, it's fine to do reps like upper, middle, lower, and isthmus, because generally we're not going to be finding too much there. Of course, if you see something abnormal, something that looks sclerotic, something that looks like it could be tumor, something that looks like it could be lymph node or even parathyroid gland, right at the periphery of the specimen, you'd want to put those through. For any dominant nodule that has had an FNA biopsy, right, this may look white or solid or different from the surrounding. Of course, always check the gross manual, but kind of rule of thumb is that, at least 1 per centimeter. If you're getting to the point where you've almost submitted the entire nodule, fine, just submit the entire nodule, it's fine. If there are prophylactic thyroidectomies for tumor syndromes, those tumor syndromes being multiple endocrine neoplasia, Dicer, or P10 hamartoma syndrome, you can, unless the thyroid is gigantic, talk to me, but generally you can submit the entire thing sequentially, because we are looking for small cancers that may not be clinically apparent. Does that all make sense? Okay. So I have a few examples of some grosses. We can do these relatively quickly, but just a word of caution. When you see the word goiter, and that's what I want to exemplify by these examples. So this is a large thyroid, 10 centimeters, 300 grams. Gross description says multiple fluid-filled hemorrhagic nodules. They took gross photos, amazing. And so what is a goiter? So a goiter is basically thyroid enlargement for any reason. It comes from basically throat or gullet. So it's basically like a goiter means you have a prominent gullet, right? It has no bearing on the actual histopathologic diagnosis, okay? So goiter could be inflammation, like Hashimoto's. It could be autoimmune disease, Graves'. It could be multiple benign nodules. It could even be cancer. But a goiter, clinically, a goiter is not a pathologic diagnosis. A goiter is an enlarged thyroid. We have to translate what that goiter means into an actual pathologic diagnosis. Okay. So this is a cross-section through that specimen. Do you here see the gross description said multiple fluid-filled nodules? Do you agree with that or do you disagree with that? Agree, multiple. One agree, two agree. Disagree with multiple. A couple disagrees, 4 disagrees. Okay, so if you look carefully, right, you can sort of see that there's a little rind here of maybe normal thyroid with a little blood vessel and a little rind here. And this entire thing, right, is taken up by a solitary, maybe heterogeneous, but a solitary nodule. I cannot find a break, right, anywhere. The entire thyroid is expanded by one thing. So the grosser didn't appreciate that this was a solitary nodule. But on histologic exam, all of it looked like this. It was this very large arc with all of this central microfollicular stuff and this small rind of normal at the periphery, right? There were no septations. There was nothing that looked like a smaller and a larger nodule. It was just all this, right? So this is a solitary, large, but dominant solitary nodule composed basically of small or microfollicles, occasionally with stromal edema. And then we say, all right, let's double check. Let's look at the ultrasound. The ultrasound agrees with the histologic interpretation. The right lobe is predominantly occupied by a solitary solid cystic mass that's 11 centimeters. So if you are not sure what's going on in your gross exam, check the ultrasound. They're usually pretty accurate. So basically, ultrasound saw a nodule, FNA showed benign. In this case, the goiter is not multiple. The goiter is a solid nodule, but we don't have a measurement for it, right? Because the grosser didn't measure it. So we were able to measure sort of at least 8.5 centimeters based on our gross image. And so remember, when you are serially sectioning anything, right, anything, and you're not sure where the lesion starts and begins, you will perhaps better be able to appreciate it after you section it. But remember to always sort of reapproximate those sections and then measure sort of where the tumor begins and where the tumor ends, and ignore, right, the ones where there is no tumor. So always get that third dimension because it is often larger than the other two. All right. But if you've cut through it, that's fine. Just slap the slices back together and measure it. Okay. Second case is another patient undergoing toxic multinodular goiter thyroidectomy. Again, giant, 250 grams. And in this case, they appreciated that the entire lobe appears overtaken by a firm, fleshy, and variegated lesion that's about 12 centimeters. And then on the contralateral lobe, right, there's nothing. So this is kind of suspicious, okay? So we have a gross photo. We have, which we'll see in a second, we have ultrasonographic evidence of a sort of left superior and left inferior nodule. That's 5.7 and 6.3. So you're asking yourself, okay, they saw 1 and ultrasound saw 2. Ideally, we are the gold standard, right? Because we have the thing in front of us. Ultrasound just has the shadows. But maybe it's 2 nodules that are tightly associated. Maybe it's 1 that's kind of bilobed. All right, we'll see that in a second. In any event, they did have an FNA. They did have a suspicious diagnosis, and molecular testing was done. So always go and find that molecular report. Usually it's in the chart. This had a RAS and a TERT mutation. When you get to head and neck service, don't worry, we'll talk about what RAS and TERT mutations mean, but it's neoplastic at least, right? We know that it's neoplastic because it has clonal driver mutations. All right, so this is a gross photograph of that solitary nodule. Again, I think you can appreciate the rim of normal thyroid and then the fleshy hemorrhagic lesion, and take note of this little satellite right here, right? So that again could mean an invasive focus, as we see on maybe histology. Take note of these maybe two dumbbell or barbell shaped coalescing nodules. So maybe that's what was seen on FNA, but this kind of looks to be maybe part of the same tumor. We look at these solid white areas or kind of yellow areas that become very cellular on histology. They sort of lose their follicular-like structures. They start to have mitotic activity. They start to have, in the bottom right, you can see necrosis and more necrosis. So in this case, the toxic multinodular goiter actually ended up being a high-grade thyroid carcinoma with necrosis and mitoses. So, you know, a goiter is not a goiter is not a goiter. So just always carefully evaluate, take pictures, and you will be able to submit great sections and make a great histologic diagnosis. Okay, the other thing I will mention is for thyroid is extrathyroidal extension. I do want to make note of this because gross extrathyroidal extension of a cancer, whether viewed by you or by the surgeon intraoperatively, like it's stuck to the strap muscles, right, is an upstage for the patient. So always look for skeletal muscles, look for large vessels, look for tumor kind of in the vicinity of these structures, and be sure to denote on the gross exam whether you see that and section those areas in your HME, in your cassettes. If we see microscopic extrathyroidal extension in the skeletal muscle in these cases, we then correlate to the gross, we correlate to the operative report in order to make sure that this is clinically significant, and we can upstage the patient. All right, questions, comments? Okay. All right, so then we're gonna move into ellipses of mucosa or skin, which generally can be treated in a similar manner, with the small exception of some melanomas, but the differences for melanomas are listed in the gross manual. We're gonna basically be discussing kind of non-melanomas. But the approach is generally the same, So as we said earlier, if they come with an anatomic orientation, please preserve it. So this surgeon says 1 suture anterior, 2 superior, 3 posterior, 4 inferior. You know, it will tell you. Often this comes with a anatomic site. So if this is labeled as tongue, okay, if this is labeled as tongue, how can we orient that? So 1 is anterior, okay, 2 is posterior, okay. 3 is posterior, 2 is superior, so now the mucosa turns like this, right, and 4 is inferior. So we can kind of get an idea based on these anatomic sites and where the mucosa is, of where it is on the tongue. So in this case, if I'm the patient, right, anterior, posterior, superior, inferior, it turns like this, we know it's the left lateral border of tongue, right? So you can gather a lot of information from that, right? So the tongue can be like this, tongue can be like this, or the tongue can be like this if you're dealing with ventral surface, right? So always remember that where sutures are very critical in orientation. And again, don't redesignate these as clock face numbers, just use the anatomic orientation. If you are not given an anatomic orientation, fine, use a clock face, right? 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Conventionally, if you're doing that, you are organizing it with the mucosa facing you, right? So it's not 9 and 3, right? It's 3 and 9, okay? So we'll start with a case presentation because this is kind of a fun one. So this is a middle-aged man. He has tongue pain. He palpated this lesion. He underwent biopsy. Hopefully you can all at least see that this is abnormal, keratinizing squamous epithelium. All right, so he's got invasive keratinizing squamous cell carcinoma. So now he opts for a partial glossectomy with ipsilateral neck dissection. There's the lesion kind of on the lateral to slightly ventral surface of tongue, and this is what the surgeon is going after. So one of our surgeons, Dr. Blair, sometimes takes intraoperative photos and provides them with the case And sometimes these are very, very helpful in order for us to understand how the specimen is oriented. And so this is a nice overview of how the surgeon tackles these, right? So they isolate this lesion, they draw a circle around it often to know where they're going to take their cuts. They sometimes put acetic acid or acetone, whatever, on the epithelium, like in Paps, right, to see if there's any like white or leukoplakic changes. And so you can see that after applying the acetone, there's a little bit of more whiteness kind of showing up here. So maybe she's gonna make her cut a little bit wider. So she estimates about a 3 centimeter area that she's gonna chop out, right? Kind of from the edge of here about to the edge of here. About 3 centimeters is her estimated in vivo area. She incises the mucosa around that epithelium. Before the specimen comes out, she puts the sutures on. So in this case, right, it's your sort of posterior, anterior, superior, inferior, okay? Before that is removed from the patient, then they make their final deep cut and the specimen comes out, okay? So that's how anatomic orientation is sort of best done intraoperatively. And there's about a 3 centimeter defect in the patient. And the specimen comes out on the chuck and it's now shrunk to about 2 centimeters, right? Because once that skeletal muscle has no sort of tether, it right? So it kind of shrinks down by about 1 centimeter. And Dr. Blair calls and says, hey, can we come and look at this specimen in the gross room? So we go look at it. And now after 10 minutes of sitting in the jar, it's now about 1.7 centimeters. So it keeps shrinking. And you know, it's interesting because the surgeons are always like, I gave you so much tissue. And I'm like, no, you didn't. And I never realized this until we did this experiment, you know? And so she's like, I took out a 3 centimeter thing. And I'm like, no, you took out like a 1.5 centimeter thing. But it's okay. We now know that this happens. We can address it appropriately. So we have documentation or photography of the overall specimen, right, with its 1, 2, 3, and 4 sutures. We have a measurement which is about 1.7 centimeters in greatest dimension. And so, I don't know, these specimens, they shrink. Who's seen this, The Incredible Shrinking Man from the 50s? He like gets chased around by his cat. It's hilarious. Many of you I don't know if you're old enough. Who knows this movie? Which is it?
It's Honey, I Shrunk My Kids.
Honey, I Shrunk the Kids. Yeah, right. So, Honey, I Shrunk the Specimen. All right, cool. Thanks for putting up with my ridiculosity. All right, so we now have our orientation. We know left lateral border of tongue. We know anatomy. We have mucosal and we have deep. We generally ink before fixation. If you don't ink and you just fix it, also fine. We can ink after, but usually we ink before. We generally serially section perpendicular to the long axis, right? So your inking should be parallel to the long axis. In this case, we're going to do superior black and inferior blue. Black and blue are the two best sticking colors. They're the two best to look at on the microscope. They don't sort of interfere with colors of tissue. So black and blue are always preferred if you're going to use 2 colors. For all mucosals and skin specimens, generally 2 colors is more than enough because you have your anatomic orientation, you have your mucosa and your deep, and now all you need is your laterality, right? So we are fine with 2 colors. I don't go crazy with 4, 5, or whatever. Just make sure that your ink covers both the deep and extends all the way up to the periphery, right? So you want to make sure in this diagram, right, you want to make sure that your ink is on also the periphery and it comes right up to the mucosa. You don't want to miss that, right? Because that is also a peripheral margin in addition to the deep. So we meet the black and blue in the middle on the bottom, and we meet the black and blue up at the mucosa on the sides. So how will you section this? Left or right? Left, exactly. Perpendicular to ink, right? If you section it this way, you've now lost that directionality, right? So the reason to ink and section this way is to preserve that laterality of the specimen. Perfect. Okay. And then once you see the tissue on the slide, right, you'll know your directionality. You'll know mucosa, you'll know deep. And then based on how it sort of turns a corner and interacts with the mucosa on the superior and inferior sides, you'll know where your peripheral margins are, right? So sometimes there's not a perfect corner, right? There's just like a slope from the lateral side to the deep side. It's all fine. It's all fine. Okay. However, we've got ahead of ourselves. Before we do any sectioning or whatever, we always use vinegar in the gross room to set the ink. So you'll notice after multiple blots and blobbing with vinegar on gauze, you'll see that the ink comes off very much your first blot, and then will come off a lot less your second and your third blots, right? So you wanna use as many vinegar and gauze rounds as you need to basically end up with hardly any ink. Because if you don't do that, you'll get a lot of seepage and leaking. So just use vinegar liberally. I like to say I use as much vinegar on my specimens as I do on my salads. I love vinegar. So just use it. Okay. And the reason that we do this, right, is because we don't want the colors leaking all over the place like kind of clown suit. So once one of my attendings in residency was like, all of these, because the breasts, right, breasts have 6 colors, right? And that's a lot of colors. And she's like, I don't know, it's like a cloud, it's like leaking everywhere. She's like, what do you do to get your colors to stay and to stick? So much vinegar, so much vinegar, so much gauze, and so much vinegar, all right? So as you all know, we have all of these colors in the gross room. And so some of them stick better than others, but again, blue and black are good. So I prefer to start with those always. Okay. Back to the specimen. So we now have the mucosal side on the top, the deep margin side on the bottom. Which side appears relatively kind of flatter? The mucosal side, right? In this case, the mucosal side appears very flat. Deep is kind of rounded. So take note of that. So when we fix specimens overnight, generally we fix all of our cancer cases, we fix these mucosal cases, because fresh, they can sort of slip and slide when you cut them. Once you fix them, they're a lot more firm and easy to cut. So first, get out your wax and your gauze, and always remember to lay gauze on top of the wax, right? Don't pin the specimen directly to the wax because it's gonna create a barrier. It's not gonna let the formalin get in there. So get your gauze in there to wick formalin through, and then get out your pins. We have small pins and large pins for small mucosal excisions or delicate specimens. Try to use the small pins because they're narrower diameter. And are you gonna pin it mucosal side up, deep margin down on the wax, or mucosal side down, deep margin up on the wax? You say left. Anybody? Left? Anybody else? You say?
Right.
You say right. All right. Right wins. Why? So in this case, the mucosa is flat. You already pointed that out, right? The mucosa is flat and the deep side is kind of hilly, right? And so if you pin the deep side down on this hill, you're gonna distort the specimen, right? So whichever side is flatter, pin that side down. In this case, it's the mucosa, so pin the mucosa down. The other reason to try to pin the mucosa side down as much as you can, I understand that there are certain tumors that are exophytic and bulky and you can't do it. But if the mucosa is flat, you then avoid distorting the specimen when you pin it, and you avoid pinning carcinoma into the margin. And I'll show you what a pinhole looks like in a second. But you can artifactually drag dysplastic mucosa, right, or carcinomatous mucosa down into your margin. And that makes it much harder to evaluate your margin status because it could all just be an artifact of your pin. It's serious. All right, then we float that thing upside down in formalin, right? So the specimen's on the other side of this thing, underneath the gauze, right? We fix it overnight. We then take it out the next morning, we serially section it, of course, perpendicular to the inks, we photograph our slices. You can see that one of the poles, right, is over here, and the other pole is over here. And we know that these poles, right, are then going to get sectioned perpendicular to that margin. So we can see tumor approach to ink. We may want to photograph relevant slices close up on higher magnification to see the relevant bits where tumor is. Here, diagrammatically, right, we then want to serially section those tips, right, those poles of the specimen perpendicular to that polar margin, and then you will be able to see how close the tumor gets to that margin. So this is kind of a histologic correlate, right, of you'll be able to see if there's in situ disease traveling and then touching ink, and you'll be able to see if there's invasive disease and how close it gets to ink, right? So that's why we do those perpendicular margins. Correlating what we see, there's a nice sort of whitish tumor here, correlating to the invasive carcinoma here. We have our second slice, and I want you to take note of both the carcinoma in the middle and this little hoo-hoo. So I bet you can already kind of guess what that hoo-hoo was from, because we pinned it, right, mucosal side down. So that's where the pin was, right? So you can see the pin on your section, and it is often this kind of hole in the middle of tissue. And so in this case, it's not as big of a deal because we have no lesion over here. But I'd rather have you sort of pinning the margin up than pinning the tumor down. Okay. Sometimes these intact, I know you probably haven't done frozens yet, right? But sometimes these intact specimens get submitted for frozen for deep margin. So what are you going to do? Are you going to look at the deep margin on the main specimen and sort of carve out a little bit? No. You are going to photograph it, ink it in your two colors, and completely serially section it as if you were grossing it. Then you will look at each slice and determine which to freeze. So you're going to freeze anything that's close to peripheral, anything that's close to deep, and if you see tumor in your end sections, you're going to have to perpendicularly section those to see if there's anything close to that mark. Okay, they are not looking for surface in situ disease. They are looking for gross invasive tumor and how close it comes to margin. So anything, I don't know, that's about 5 millimeters or so within margin, freeze those. Always ask us for help. But basically what I'm trying to tell you is when you get this for frozen, you're going to have to basically gross it at the time of frozen. Okay. All right. How much to submit? If it's small like this one, fine, you can submit it entirely. If it's large, we want to do representative sections of tumor, including representatives of margins. Representative to each of your 4 margins and representative to your deep margin, okay? I know for breast, they sometimes say submit your entire polar margin and then reps of the middle and then your entire other polar margin. For cases in which you are not submitting the entire specimen, right? Let's say this was big. You do not need to submit this entire margin or this entire margin. Pick representatives that are closest to tumor, just like you would for all of your middle slices. And then you label them with numbers on your gauze, right? 1, 2, 3, 4, 5, 6 on your paper towels. Roll them back up in order, and we have things for later if we need to go back. Does that all make sense? All right, questions? Laryngectomy, laryngopharyngectomy, maxilla, mandible, just call. Please just call. We are more than happy to come. There are 3 head and neck attendings, 1 head and neck fellow. We love to come and look at the specimens. All right, so in the last few minutes, I wanted to talk a few minutes about gross photography. I have a whole lecture on gross photography on the website that you can download. But this is kind of my hot key tips. All right, so we don't want to take bad photos because sometimes we can't fix them, right? If they're bad to begin with, we can't magically fix them in Photoshop, but there are certainly some things that we can do in our softwares. I don't believe there's a general resident Photoshop, but many of the faculty have them if you do need to clean up images for presentation or whatever. There is this free online software called GIMP, which basically mimics the functionality of Photoshop. So if you want to play around with this on your own, awesome, have fun with it. So in general, how to take a good photo. So we don't have to do too much manipulation. Use that plastic background in the gross room. It's, I think, blue, it kind of moves around. Keep it clean, right? Put the ruler with your surgical path number, and generally people like to put their initials so they get credit for taking a nice photo. Zoom in as far as possible to maximize dead space, right? If you have zoomed out very far, you're wasting pixel information, right? So zoom in as far as possible. We like to take pictures of the overall specimen, uninked orientation. If the inking is very complex and you want to document what you did, you can take pictures after inking. You definitely want to take pictures of your cut sections to see what this tumor looks like. Make sure you clean off any sort of running ink that may have gotten onto those cut sections. You could certainly take pictures overall of every single slice if you wanted to, but also then please isolate a couple good ones, zoom in and take pictures of those really good representative cross sections showing nice tumor. I tend to take one picture with the light stand off and one picture with the light stand on, and I'll show you why in a second. So in this case, what's wrong with this picture? This was our old gross room where we had a black background, but what's generally wrong with this picture? Yeah, it's super far out, right? Like what is really the point of having 99% of your space being background, right? So don't lose the trees for the forest. Zoom in so that the object fills the frame. The macro path does have those preset zooms. It's like 0, 25, 50, 60, 80, 100, whatever. It's fine. They're not perfect, but use them. If you zoom in as far as possible and you've like cut off the thing, just step out, right? I'd rather have you zoom too far in and step back out than not zoom in enough. So use as much pixel space as you can for the actual specimen. You say, why can't I just crop it later? Well, okay, a few reasons. First, the camera focuses and adjusts the exposure better if the tissue fills the frame. So if the tissue does not fill the frame, the camera is auto-exposing on the background. So it may underexpose the tissue and you won't get appropriate exposure. Thing one. Thing two, the resolution on the macro path stand is not extraordinarily high, right? So if you're cropping it down and you want to publish it, you now may not have enough pixels per inch, right? So for those two reasons, better exposure and better resolution, just zoom in. In this case, right, it's very, very, very dark, right? And so this again was taken with our old like Canon single lens reflex camera that you could adjust the exposure settings. In the macro path stand, you really can't adjust the exposure settings, but you probably can. It's advanced. Call me if you need help, but you can certainly adjust your lighting conditions and you can adjust your zooming in and your zooming out. And so, especially with three-dimensional things, of course, this is like a cut section of a lesion, but with three-dimensional things, sometimes the photos turn out better with the direct lights on, and sometimes the photos look better with the direct lights off. And so the coloring can be subtly different. So the overhead lights in the room, right, these things are fluorescent bulbs. And then the bulbs in the light stand were, or probably still are, sort of tungsten bulbs. So does anybody know which is fluorescent and which is tungsten based on the color? So it's sort of differentiated into left and right. So which is more cool tone? The left. So the left is fluorescent and the warmer tones are more like regular tungsten bulbs. The overhead fluorescent light is more diffuse, right? So you get a bluish overcast and you don't get as many shadows, or you get shorter shadows. The bulbs on either side, right, are very directional, right? And so they're actually casting these longer shadows, right? So you can see these longer shadows. And sometimes, depending on how sort of, I don't know, voluptuous the specimen is, you may not want those direct lights that cast shadows on the internal parts of the specimen, but you may not know which looks better until you've taken one off and one on. that's all I'm saying, just take one off and one on. You'll get slight color tonality differences, and you'll get differences in the way that the shadows are cast on the specimen and on the background. Okay, sorry, I come from an arts background, so thank you for bearing with me on that one. Okay, in this specimen, what's wrong? It's zoomed in a pretty decent amount. It's got some shadows, but okay. It's dirty, right? There's black ink all leaked into this tumor, and the tumor looks like it's this blobby gray thing, right? So please don't just cut into it and throw it on the thing. Look at it and say, oh, did I accidentally cut ink down into the specimen? If you did, it's okay. Just get water. It's not going to harm the tissue with a little bit of water. Just try to wipe it off or clean it off as much as you can so that we don't have like inky, nasty stuff covering the cut surface. Okay. What's wrong here? What? Okay, no ruler. So you don't know how big it is, true. What else? Sections are attached. Sections are attached. So I am of the opinion, and others may differ, and if you're taking a picture for me, please don't bivalve it, right? Like a clam. There is no reason to keep these intact. You know, you look at it and you separate it, you know how they go back together, right? It's not freaking hard, right? The faces match the faces, the fat matches the fat, right? This is obvious where the orientation is. So there's no need to keep these hanging on by a useless thread. Does keeping the specimen partially intact, photograph, mirror image actually add anything? Usually not, right? So section completely through and photograph one half or one complete cross section. It's a nicer demonstration. Similarly, right, you have this is not a mastectomy. I know for mastectomies, we have to keep the anterior intact to keep all the slices. I get it. That's a different ballgame. But this is an unoriented, totally inked black soft tissue tumor. Is there any reason to keep that hinged? Absolutely not, right? You are displaying something where you can't really tell what's going on. I have no idea how far the tumor approaches that other margin, right? You're basically losing information in those crevices. So again, completely cross section, bread loaf it. Don't bookend it, right? Bread loaf it, don't bookend it. And then you can, as we saw with our mucosal ellipses, right? You can 100% lay them out in order, number them, and wrap them back up, and it's fine, right? So please cut completely through, and you can Humpty Dumpty it with gauze, right? You can wrap it right up, and it's fine. If you do that, and you have your slices separate, always try to put some kind of paper or gauze in between those slices, again, so the formalin can wick in and fix those faces. Otherwise, if you have the faces stuck together, formalin's not going to get in very well in there. And remember, how fast does formalin penetrate? Yeah, it's really slow. It's really slow. So the more volume of formalin, the more gauze in between, the better. Yes.
Well, myself to say I think I took a bad picture.
Okay, that's all right.
So what happened was like I had a thyroid that I then like completely sectioned and then put like in one row.
Okay.
I only zoomed so far into all section. So in that case, would you recommend like stacking rows? And then if we do, like, is there a particular way that you want us to stack them or like label them?
Label them using the macropath annotations.
Okay.
Because you know there are annotations in that software, yeah. Okay, yeah, the PAs and stuff will help you, but so yes, if you do want to take every single slice, you can certainly put them in rows, and then you can say, you know, top left is slice 1, superior, and top right is, and they go in this order or whatever. And then, like you said, that's great for overall, and then maybe pick a couple nice ones and then isolate those and zoom in on those. Yeah. It happens all the time. But thank you for coming out. Okay. All right, so examples of good, right? We have fresh, right? We have fresh front and the back of the specimen. You can see here that there's a nice glistening fascial plane. You can see here that this is sort of raggedy fat. You can see the anatomic orientations from the surgeon. You then have a full thickness cross section of the fresh specimen, showing nice kind of tumor and its orientations to margins. For a nice colon here, you have kind of the overview of the main mass in the luminal surface. You have a close-up of what that pedunculated mass looks like. You have a cut cross section of that mass as it sort of approaches the muscularis of the colon. So these are kind of nice. You know, we as surgical, you know, attendings, pathology attendings, don't always have the privilege, right, of seeing the gross specimen that you do. And pictures are, the saying is true, right? They are actually worth hundreds of thousands of words, right? So you can write all the gross description that you want, but if it doesn't get across what you've done, then it's poor, right? So if I had my druthers, I would make pictorial gross descriptions, because to me, it's just so easy to understand what's going on when you see it. So always, always, always supplement with many, many photos. You will never be faulted for taking more. That's my cat Stormy. Thank you for listening.